Okay, hi guys. I'm back with the last part of the HAEM 5 paper discussion series in just the classification. Last time there were some errors that I made while speaking. That is, I read the table, updated HAEM 5 as HAEM 4 and the HAEM 4 as HAEM 5, which I corrected when was it was brought to my notice. Sorry for the confusion, and that thing I uploaded last week. So today I'll finish with the entire paper. Then we are going to start with individual series of the same paper. After that, the ICC. Okay, and then hopefully the myeloid. If someone has, you can message me in the YouTube comments, or I'm gonna search the whether it has the myeloid thing. I think it has come out. I'll have to check the changes in the myeloid classification, and I'll start with that. Hopefully we'll get the soft copy of Blue Book. It should have come out. Let me just check again. I have not checked. By December you'll get the hard copy of the Blue Book. And so without wasting any more time, the article. Okay, so again the left part is the fifth and this is the revised fourth, that is the old edition. So stroma derived neoplasms of lymphoid tissue, these have been added. Mesenchymal dendritic cell neoplasm. Now follicular dendritic cell sarcoma was there before also. EBV positive inflammatory follicular dendritic cell sarcoma. This classification name has been used instead of inflammatory pseudotumor like follicular or fibroblastic dendritic cell sarcoma. So they must have found an EBV origin to this tumor and hence named it EBV positive inflammatory follicular dendritic sarcoma. I have not come across these till now. I don't know how frequent you come across them, but for exam purposes, you need to remember. Then fibroblastic reticular cell tumor remains the same. Then there's a group of myofibroblastic tumors, which includes intranodal palisaded myofibroblastoma. This was not there before. Okay, so mesenchymal dendritic cell neoplasms were there, we all know. So in that EBV positive inflammatory follicular dendritic cell sarcoma. So the first name is form follicular dendritic cell sarcoma. Now just to this add EBV positive inflammatory. So there are two things in mesenchymal. And of course fibroblastic reticular cell tumor. Myofibroblastic group has been added in hematolymphoid group under the name intranodal palisaded myo in the nodes. Splenic vascular stromal tumors, littoral cell angioma, splenic hamartoma, and sclerosing angiomatoid nodular transformation of spleen. This is important if you're preparing for MLEs. Okay, in our case, littoral cell angioma, yes, we've heard about hamartoma and sclerosing angiomatoid nodular transformation of spleen. All these three things have been added, which were not there before. So these tables are important. Whatever I'm saying, if we just remember the tables, these things, keep going back to them, I think slowly we'll be able to register the heme 5. So this part is the summary of relationship between splenic B-cell lymphoma entities as named and defined in 4th edition of the WHO and in the present 5th edition. Okay. I told you na, that there are some splenic large B-cell lymphomas with large nucleoli and PLL and hairy cell variant have been removed. So this is discussing that entire genre. Okay. So hairy cell leukemia in heme 4R. The classical one remains hairy cell leukemia in 5. This is 5, this is 4. Splenic marginal SMZL remains SMZL. Okay. Also SMZL in heme 5, there is a category of SMZL which initially was just put blankly in splenic marginal zone lymphoma, which has now been defined as splenic B cell lymphoma leukemia with prominent nucleoli. So the SMZL category in 4 has been divided into 2 and 5. One is the classical SMZL, and then there is a category of splenic B cell lymphoma leukemia with large prominent nucleoli. Splenic diffuse red pulp small B cell lymphomas leukemias as well as, so only the first one if we go with the diffuse red pulp leukemia lymphoma remains the diffuse red B-cell lymphoma leukemia. Ho- However, hairy cell leukemia variant has gone into the large prominent nucleoli category. Okay, so hairy cell remains hairy cell. Marginal zone is marginal zone, as well as some population is that large nucleoli. Red pulp leukemias remain the same in the spleen. Variants go to the prominent nucleoli category. BPPL divided into three. PPL वाला category खत्म. एक होगा mantle cell में चला जाएगा. One group goes again to that prominent nuclei, and third is a pro-lymphocytic progression of CLL instead of calling it BPLL. CLL and small lymphocytic CLL if greater than 15%. Initially up to 10, then 11 to 55 and more than 55. ऐसे divide होता था to call it a PLL. Now if more than 15% pro-lymphos are present, just go and straight away call it pro-lymphocytic progression of CLL. Even if you get 55% pro-lymphocytes, you still call it pro-lymphocytic progression of CLL, not BPLL. Okay. Then that was about the splenic lymphomas. This is about the extranodal marginal zone lymphomas, etiology and recurrent genetic abnormalities in extranodal outside the node EMZL at various sites. Etiology: C. Helicobacter pylori and related species seen in stomach. This is a list of mutations. BERG3 MALT1. So stomach, BERG3 MALT1 H. pylori. Promote NF-kappa beta activation. Then comes Achromobacter xyloxidans seen in lung. Now in lung you'll get a MALT1 mutation also, IGH BCL10 and IGH MALT1. Okay, so BERG MALT1, IGH MALT1, lung gets everything. Again, promotion of NF-kappa beta. Chlamydia psittaci, ocular adnexa, TNF-API3 mutation deletion, again NF-kappa beta activation. Sjogren's syndrome in salivary gland has a list of mutations: TBLXR1, MID88, TNF AIP3, enhanced G protein mediated signaling, as well as NF-kappa beta mutation. Hashimoto's again from mid-88 going to this green PIK3CD, all these mutations reduce co-inhibitory regulation of T helper cells, NF-kappa beta activation, and enhances G protein mediated signaling. Borrelia burgdorferi in skin, a big list of mutations again: apoptosis protection, reduce co-inhibitory regulation of T helper cells, enhance G protein signaling, and promote NF-kappa beta. So basically, remember a few of these: the bacteria correlating to the site, and of course the method of propagation of the tumor. Then coming to summary of relationship between large B-cell lymphomas, entities as named and defined in the revised 4th edition heme 4R, and in the presence. You know that certain categories have now been removed and just put under a large blanket. Okay? So let us of large B-cell lymphomas or lymphomas of immune privileged site, etc. So let's come to that. So over here this is 4R, this is 5. Primary DLBCL of CNS. In any immune deficiency setting, or generally when EBV associated, is now known as immune deficiency dysregulation associated. If there is no setting of immunodeficiency in a tumor of CNS looking like a DLBCL, just call it LBCL of immune privileged site. Don't call it DLBCL of CNS. Okay. DLBCL NOS, again in immune deficiency settings, over here IDD, call it immune deficiency dysregulation associated lymphomas. If it is in testes and retina, call it LBCL of immune privileged site. If both of these things are absent, then you can call it DLBCL NOS. High grade B cell lymphomas with MYC and BCL2, or the triple hit lymphomas, that triple hit MYC6 has been removed. So MYC-R and BCL2 gene and BCL6, just call it DLBCL NOS. MYC-R, BCL2, BCL realignment, or go to DLBCL, or just call it high grade. If both are present, call it high grade B cell lymphoma. MYC is rearranged. See, MYC is rearranged in all these three. BCL2 is rearranged in the lower two. BCL6 can plus minus be rearranged or not, doesn't matter much. So you will divide it into NOS in DLB cell high grade and in rare B cell lymphomas if you get all the three rearranged. B cell lymphoma unclassified again has divided if there is immune deficiency setting. Blindly in any DLBCL, if there's an immune deficiency setting, just no, call it IDD. If it is extramediastinal, call it NOS. Nothing, just call it gray zone lymphoma. So the word gray zone lymphoma has been brought back. Then algorithm of classification for aggressive B-cell lymphomas in heme 5 in the light of MYC BCL2 and 6 rearrangement and complex LQ 11Q gain loss. DLBCL can be MYC rearranged or not. Then you go for BCL2 and BCL6, call it DLBCL. Burkitt's lymphoma, the 11Q gain and loss, one, I mean, I'm not reading the whole chart, but I want to tell you this. You can go ahead and read it because you'll take some time to remember. Burkitt's lymphoma, that 11Q mutated Burkitt's like lymphoma, has just been called high grade B lymphoma now with 11Q mutation. And it also has MYC rearrangement. It might not have MYC rearrangement, and BCL2 and BCL6 might not be there. It might just have 11Q rearrangement. The features are Burkitt's like, but don't call it Burkitt like. Just call it HGBL 11Q rearranged. Okay. Then primary B cell lymphomas of immune privileged type, CNS, vitreoretina and testis. तीन sites के हैं. Usually in adults, aggressive. They look like large B cell lymphomas. Are MUM1 and BCL6 positive, EBV negative. Mid88 and CD79B mutations are seen. Okay. Then these are post-transplant lymphomas. A lot of them in the heme 4 are. Some have been, reduced in heme 5. So all the PTLDs can now be known as hyperplasias, follicular, mononucleosis like plasma cell type and KSHV type. Then HIV associated lymphomas have become polymorphic LPDs, EBV, MCU. Other iatrogenic, they have just, either polymorphic LPDs or just lymphomas. Then LPDs with primary immune deficiency, these types have been given. These all types. So the PTLDs and the immune deficiency, the prime lymphomas, leukemias, have now been further classified like this in heme 5. Okay. Histological diagnosis of immune deficiency dysregulation. You read this. Basically, these viral entities, they have mentioned EBV separately also, and then they have mentioned its association under immune dysregulation lymphomas also. And these immune dysregulation lymphomas have a they look like either follicular hyperplasias, they might look like polymorphic lymphoproliferative disorders, like can have mucocutaneous ulcers or just unclassified lymphomas. And then the deficiency that you get is HIV. They can be after transplant. There might be autoimmune problems. It is iatrogenic. There can be inborn errors of like PIDs, etc. and immune senescence. So ये पहले अलग डिफाइंड था. अब इनको etiology एक में क्लब कर दिया गया है. अलग अलग पोस्ट ट्रांसप्लांट एसोसिएटेड, HIV एसोसिएटेड ना करके एक ब्रॉडर हेडिंग में क्लब करा है. etiology वही है. और स्लाइड देखोगे तो इस तरीके के लीजन स्लाइड में मिल सकते हैं. ओके. Then this is just a pattern of LPHL, the 6 patterns A, B, C, D, E, F. This is for your knowledge. You need to remember this. Then this chart is there on the table in that article. You can download it, where they have compared different type of NK cell lymphomas and their features. I'm not going into detail, but you need to know. Just read it. When we do the individual lymphomas, we are going to take it one by one. Okay. Germline mutation tumors now have ataxia telangiectasias, Nijmegen breakage syndromes, and ATM and NBN have links to a lot of lymphomas. So these germline mutations are now being considered in this classification. And then for this is the same thing, that revision table that I have in the end, that follicular grading has become redundant. Okay, you can write it, but they don't consider it important for treatment of the patient now. 3B has become follicular large B-cell lymphomas, DLBCL, GCB, and ABC type retendant but retained. Double hit lymphomas are named as DLBCL or high grade B-cell, MEC and BCL2 rearranged. BCL6 is no longer a hit. So triple hit lymphoma is removed. Burkitt-like lymphoma with 11q is renamed as high grade B-cell lymphoma with mutation. Then immune privileged side, mediastinal gray zone is back. Burkitt's has a classically EBV positive and negative classification. CHL subtypes is redundant but retained. NLPHL is now NLPDL but not done till yet, going on in trials. Then medical renal disease, CAD, TEMPI, AirSoc, these entities have been added, especially where plasma cell lesions are concerned. Kikuchis, ALPS, ITLPs have been added. Lymphoblastic NK cell wala naam has been removed. No NK lymphoblastic leukemia is there now. NKCLPD is renamed as NKLGL. Then cutaneous T cell lymphoma subcategories made separate entities now. HSTL no longer disease of young. ALCL subcategories made into 3 entities. DUSP22 is no longer considered favorable and ALK negative. Extranodal NK T cell lymphoma, nasal word has been dropped everywhere. So this is in short the entire paper. Now we'll take one entity every time we go about, just to see what each heading entails, because this is quite confusing. I understand we'll have to go through it every time to start bringing it in our practices. So till then, please read that paper, download it. This is just for your help. You'll have to read that paper, and then we'll start taking up individual topic from that paper next week. So thank you.